Hi, everyone. My name is Maria Sedeno, and on behalf of RESPIPLUS, it's my pleasure to present you to today's webinar, Protecting Vulnerable Canadians, Enhancing Pneumococcal Vaccination Awareness and Update. And we're very pleased to be able to offer this continuing education opportunity, and which was made possible by an unrestricted sponsorship from Merck Canada. Just a couple of technical aspects before we start. If you have any questions, we're going to be using the Q&A section at the bottom of your screen. Actually, the chat section is locked, but the Q&A is open. If you're connecting to the webinar by phone, please note that your phone line will be muted during the session and cannot be unmuted. And also, please note, this webinar is being recorded and it's going to be available, and we'll be sending you a link in about 2 to 3 days, and you can watch on expandcourses.com. Now let us introduce to our fantastic guest today, Dr. Alan Kaplan. He's a family physician based in Ontario. He is the chairperson of the Family Physician Airways Group of Canada and the vice president of the Respiratory Effectiveness Group. He's a clinical lecturer at the University of Toronto in the Department of Family and Community Medicine. Dr. Kaplan is also a member of the Medical Advisory Committee of the Pulmonary Hypertension Association of Canada and a member of the section of Allergy and Respiratory Therapeutics in Health Canada. And with that, Alan, welcome.
Maria, thank you. Thank you, everyone, for joining. We're going to talk about pneumococcal vaccination. I'll touch on all vaccination because I think that's relevant for us as clinicians. Overall, we're going to talk here about the burden of pneumococcal disease, the landscape of vaccination, the barriers that I think we all face, and how we can potentially improve our management, and give you a few resources that ResPlus has provided for us. Here's the committee that created this talk. I want to thank everyone involved. You've met Maria, Katrina, also from ResPlus. And we have some specialists and some pharmacists also involved, and I want to thank Merck Canada for their unrestricted grant. So here's the potential for conflicts that I think everybody who is in this group all has conflicts with various companies. Here's my disclosure overall, says some of the things that I do. And I work with many companies that make vaccines, including Merck, GSK, Pfizer, and Moderna. So I'll start off with, and again, I didn't realize the chat was going to be locked, Maria. So I threw this in. What do these people all have in common? So I was going to make you all guess and say who they are, but I guess we won't be able to do that now. So, these are some people, and the point here, and on the left top is James Brown. This is Jack LaLanne, who was a fitness guru in the 70s. Charles Bronson, you'll recognize. This is Jim Backus, who was Thurston Howell III in Gilligan's Island, for any of you can remember. Jim Henson, Fred Astaire, and Freddie Mercury. These people are all fairly famous people in great shape. What do they all have in common? Well, what they have in common is they all died of pneumococcal illness. So it doesn't matter how rich you are, how successful you are, how famous you are, the bacteria and viruses of the world don't care. They will kill you anyhow. And that's really the bit of sobering thing we have to think about here. So we're going to talk about the burden, the new NACI recommendations on pneumococcal vaccine. We've done a national survey with RESPIPLUS looking at pneumococcal vaccination with some interesting learnings that I think will help us in our practice. And then we'll talk a bit about barriers. So we're going to talk about the burden both globally and Canadian, how the disease manifests, and who the particular risk groups are, and I'll come back to that. So what is Streptococcus pneumoniae? First of all, well, it's a bacterium called Streptococcus pneumoniae. That's the pneumococcus you've heard of. It's a very significant cause of human infection, mostly affecting the respiratory tract, but it can also become a cause of sepsis. It's the fourth leading pathogen causing worldwide deaths, and it is associated with antimicrobial resistance. Why this becomes important is if you have a bacteria that antibiotics can't kill, it's really hard to make somebody better who gets those illnesses, as you all know. We're spending a lot of time trying to promote antibiotic strategies to reduce antibiotics, to reduce this, but it's still a very big issue. And Health Canada has a list of things they call pathogens of interest, and it's there. Now, what's particular about Streptococcus pneumonia is it's covered with a capsule, and that capsule has little proteins, and those proteins really describe the serotypes. There's over 100 serotypes that can cause invasive disease, and many of those can be prevented by vaccination. So it's a vaccine preventable disease, or a VPD. So we have something to think about, that some things we can't prevent are going to happen, but some things we can, and we owe it to our patients, especially at risk, to do that. So overall, the presentation, we talk about, first of all, milder things because pneumococcus lives in our upper respiratory tract, so it's a cause of sinusitis and otitis media, which are obstructive problems. It can lead to a non-bacteremic pneumonia, or it can evolve into an invasive disease where it's bacteremic pneumonia, bacteremia, and meningitis, and sepsis, and even death. So obviously, the more you move up this triangle and the pyramid, the more severe the presentation is and the worse the outcomes, and the more important even to prevent it. So, who is at highest risk for pneumococcal disease? Well, the very old and the very young. And it probably has a lot to do with the immune system, and I'll come back to that. But our immune system is developing when we're very young. And as we get older, our immune system starts to unfortunately fail. A couple of factors in the immune system as we get older. One is the concept of immunosenescence, which means the immune system just fatigues. We don't have as many memory cells. We can't mount the same response. And inflammaging is the other thing you're going to hear about, wherein people actually start having a low grade inflammation all the time. And that low grade inflammation, therefore, leads them susceptible to those bursts of inflammation that occur because of inflammation, because of infection and the release of cytokines. So I'll come back to those topics. So again, you're thinking about the fact that we get into these ages, the risks are, it's not the risks are zero, but the risks are quite low as long as you don't have a lot of comorbidities. But the biggest issues are going to be the young and the old. We're going to focus on the older patients today. So what are those other comorbidities I mentioned? Because other than just age, there's a lot of other things to talk about. Well, the first big group are those who have immunocompromising conditions. And I think you've heard all about this already. You should know all these lists already because we've been living COVID the last number of years. So you're just used to looking at these issues. So I won't go into great detail, but you get the idea that if your immune system can't respond to an infection, you're likely not going to do as well. So whether it's going to be HIV infection, cancer, or chemotherapy, primary immunodeficiencies, immunocompromising therapy such as chemotherapy, or transplants on medications to prevent rejection, and even the biologics that we use, T cell biologics for things like rheumatoid arthritis and Crohn's and psoriasis. These all affect T cells and therefore do that. Some conditions in themselves affect immunity, such as nephrotic syndrome and sickle cell disease, probably related to not having a spleen that's functional because the spleen gets knocked out with sickle cell. So you're thinking about that group. The non-immunocompromising conditions are basically what we spend all of our days treating. These are the patients that have chronic illness, and it can be any of a number of these conditions that are listed there. I won't go through them. The last two there, CSF leaks and cochlear implants, unfortunately, are a portal to get meningitis, so that's why they're on that high risk. But basically, any condition that affects your body's ability to respond to an infection and survive it is going to be in that list. There's going to be external factors, where you live, how you live, what you take in terms of smoking or alcohol abuse. Of course, if you're not living someplace that's safe for yourself, whether it's homelessness, whether it's going to be congregate homes, and of course, oftentimes we look at high risk in terms of being native Canadians who tend to actually have congregate home issues as well. So these are some of the things we're going to think about. So we look at age. We look at these lists of comorbidities that people have or living conditions that make them at risk. And then you say, well, what if you put them together? So in this slide, we've actually done, if we put age, gray is 50 to 64, and the burgundy is over 65. And what you can see here, there's an increase, there's a risk of having these conditions. If you look at right in the middle, chronic lung disease there, the risk per 100,000 is 231, 50, 64. But if you take that group and take them over 65, they've got double the risk. So age actually increases the risk on top of the comorbidities. The other way to look at it is having comorbidities is in itself a risk factor. Well, then, if you have one comorbidity, what if you have multiple comorbidities? And those of you that are in practice, when you're seeing a patient now and they're into their 60s and 70s, 80s, it's very unusual for people not to have a number of comorbidities. What you can see here, the gray healthy, the green 1 at risk, the light purple 2 risk, the burgundy 3, and the darker green high risk. So what you're seeing high risk would be the overall or high risk. But if you put 3 risk conditions together, you look at the far right or even the second one, you can see that having 3 conditions is even higher than that high risk overall. So having a number, so age, comorbidities, having multiple comorbidities, you can see are that population of yours that you're looking after that are very high risk. And this is high risk for all the respiratory illnesses that I'll touch on at the end, but we're going to talk about this for pneumonia. Other conditions to think about are going to be obesity, going to be smoking, and so on as well. They're going to put you at risk. So I talked about Indigenous Canadians at higher risk, and there's a variety of different reasons why, whether it's overall health status, whether it's behaviors, whether it's living conditions, and so on. But the bottom line, they're much more likely to get invasive pneumococcal disease and much more likely to die of invasive pneumococcal disease. Is it immunocompromised? That's the issue. There's a variety of factors that are there. But the bottom line, that's a population that we have to think about. So where are we in Canada with pneumococcal vaccination? What are approved? What does NACI, the National Advisory Committee on Immunization, say? And then we'll touch on our survey. Well, how are we doing for vaccination? Unfortunately, across the board, across all these different vaccine preventable illnesses that we should be aiming at, the government has set a target of just around 80%. And what you can see here for pneumococcal, and on the left is 18 to 64 with a chronic medical condition, only 1 in 4. A little bit better, almost 60% of people over the age of 65 have had it. But then we have to think also about what vaccine they've had, and I'll come back to that. Influenza, you can see less than half under 65, 70% over 65. So there is some penetration of vaccine recommendations in there. Tetanus, again, you need tetanus updates, and even as far as respiratory world, it should be pertussis, thinking about tetanus and pertussis. Again, 70%. You can see that it's very small for pertussis, 1 in 3. Part of that's the rules, 1 single dose over the age of 50, but I think many of us are giving that as our routine vaccination. The point here being is that we're woefully undershooting our target. Never mind the fact that the target shouldn't be 80, it should be 100% of your patients who are at high risk, which means anybody over 65 and anybody with chronic medical condition. And think about it in your practice and how well of a job you're doing getting people vaccinated. Putting things in perspective, if you go back the last 150 years, what is the number one thing that has saved lives? And no, it's not vaccination, it's clean water. But number 2 after that is vaccination. So we've done more to save lives with vaccination than treatment with antihypertensives and lipidemic agents and a whole bunch of things that we do. Vaccination saves the most lives. So we have to think about and put that in our important areas where it is there. So we've gone through quite a bit of change in terms of pneumococcal vaccination over a period of time. And what you're seeing here, it doesn't even go back far enough. We have to go back to Prevnar 7, which was given to children, and that caused some herd immunity. That got changed to Prevnar 13. Those are both conjugate vaccines. Before we did that in adults, we were using Pneumovax 23. Now, Pneumovax is a polysaccharide vaccine, which induces a response with B cells to release IgM antibodies. Unfortunately, what we didn't know is that actually that B cell response actually is fatigable. And again, for many years, I was asked in many different countries, what's the best recommendation for the 23? And we were probably wrong in our recommendation because this is not a very good vaccine. It does reduce invasive pneumococcal disease, but it does not do a very good job on community-acquired pneumonia. So for years and years and years, we've been given this vaccine. That's what the government decided was covered, and that's changed, and I'll talk about that shortly. So we had this polysaccharide vaccine. Then we recognized how important it was to use a conjugate vaccine. The conjugate vaccine creates a memory. So it induces T cells to release T cell killer cells and helper cells, and therefore have a memory to actually remember. So when you get exposed, you can fight it again. So 13 has now been replaced mostly, depending on where you are in the country, with 15 and 20. And I'll come back to that. So 13 has 13 serotypes, 15 has 15, and 20, as you can imagine, has 20. And Capvaxive, the new one, has 21. But they're not necessarily just adding to that. And I'll show you a little bit about that shortly. So those are the ones we have available. And we'll talk about which ones are paid for by the government. And again, it's different in different provinces, and which one is not, and how you can access it. Well, again, who should we be aiming at? So if you look at people who get community-acquired pneumonia and invasive pneumococcal disease, most of them are going to be over the age of 50. So you can see in terms of community-acquired pneumonia on the top, 50% over 65, 81% over 50. Invasive pneumococcal disease, which is much less common, thankfully, because it's much more fatal. Again, about half in over 65, and again, 80% over the age of 50. So what you're looking at here is that 50 seems to be a pretty important marker as well, especially if you have those comorbidities. So 65 is that higher risk, but it's time to start talking about this at 50. So an adult vaccine is starting at the age of 50. What happens when you have community-acquired pneumonia in Canada? Again, it's worse based on the different ages, but again, starting at the age of 50, which is the gray bar, you start seeing an increased risk of admission, mechanical ventilation, complications, mortality, and morbidity. So community-acquired pneumonia is not a little thing. We've all heard it being called the old man or old woman's friend because of significant risk of mortality. This is 10% at 30 days. And the mortalities really haven't changed in many, many years, despite antibiotics and ICU care, because some of those bacteria release a bunch of cytokines and cause sepsis, and some of them are resistant to antibiotics. So we have a problem here for a condition that's partly, not all community-acquired pneumonia is preventable, of course, because it's not all pneumococcal, but it's partly preventable. The immunocompromised population is at much higher risk. So you think about those people in your practice and make sure they're prevented, please. Okay. Your patients who have transplants are getting this advice from the transplant units. Many of your patients that are being transitioned to T-cell biologics, the anti-TNF biologics, will have advice from their specialist, be it their dermatologist, GI, or rheumatologist, but not all. So if you see a patient going down the pathway where they're going to end up needing a biologic, then think about getting them vaccinated. Asthma biologics are not the same. COPD biologics, which are along the same lines, currently are not shown to increase risk of infection, but those other biologics we use for those other conditions are. So again, preferably get them vaccinated before you're starting the treatment. If you have somebody on a waiting list for a transplant, get them vaccinated now. If you have someone who's got Crohn's and you can see them moving toward a biologic, get them vaccinated now, because immunocompromised patients, vaccinating them doesn't work as well, as you well know, because their immune response is suboptimal. So immunocompromised Canadians are at the highest risk. Now, NACI's recommendation as of November this last year said the following: adult pneumococcal immunization programs in Canada should occur, okay, and they should include at least one of Pneumo 20 or Pneumo 21. I'll get into the different vaccines shortly. Okay, again, either one of 20 or 21, regardless of their previous vaccination of 13, 15, or 23. So if they've had any of those previous ones, it isn't protecting them enough, and they should be given a 20 or 21 over 65, especially if they're increased risk of invasive pneumococcal disease. Now, there's a difference between 20 and 21, and I'll come back to that. But in those highest risk people, hematopoietic stem cell transplants, these are people that are getting their bone marrow wiped out and replaced. They're getting a transplant of bone marrow to try to recreate their bone marrow. They have absolutely no immunity at all until their new bone marrow kicks in, but they're still going to be on anti-rejection drugs. So they don't have very good immunity at all. They're the highest risk. NACI recommends for this group that they get both the 20 and the 21 because they feel that the added coverage of the 21, which I'll show you, is worthwhile to add it in. Everybody else, it's 20 or 21, although I think if you have someone who has high enough risk, you might want to say, well, do you want the 21 on top of even a 20? That's not currently NACI's recommendation, but I do personally offer it to patients, and I'll show you why. This is the Quebec protocol, the protocol of immunization to Quebec. And here's what the rules are. If any of you are from Quebec, these are the rules for pneumococcal vaccination, as well as many of the other vaccines. So you can look this up online, PIQ. Okay, so I showed you this already, and we said, okay, it's highest in the young and the old. But in the young, you can see we've done a really good job at reducing. That's because children get vaccinated. But in adults, we have not reduced the issue of pneumococcal illness. Well, children are getting vaccinated. 85% of kids are getting pneumococcal vaccine, whether they get a 3-dose or a 4-dose, depends on where you are in the country. But bottom line is they're getting vaccinated. Well, what about adults? I've showed you this already, that only a quarter of high-risk adults 18 to 64 are getting vaccinated, and around a half of over 65 are getting vaccinated. So we have a few reasons why we have not improved this adult vaccination overall rate. Number one is going to be the fact that we're not getting vaccinated for it. And number two has something to do with what I alluded to, which is the serotype coverage, which I'll come back to. So we have some work to do. Here's Ontario recommendations, and it's not the same across the country. At the end of the talk, there is a link to some resources. Those resources will not be active right now. They'll be active when we send you the follow-up information from this as those have registered. But you'll see where, depending on where you are in the country, the vaccine recommendations and the coverage. BC, for instance, only covers 23, which makes no sense to me at all. But in Ontario, they've just made a big change, and I'm very happy about this. So they said, let's talk about 65 and over, the middle group here. They used to pay for Pneumovax 23. Not a very good vaccine. We've been saying, many of us have been saying this for many, many years. Why are we paying for a vaccine that is almost useless and actually fatigues the immune system? Well, now the recommendation is 20. So the Prevnar 20 is now covered over the age of 65. For children, they went from the 13 to now the 15. If you're high risk child, then it's 20. And if you're high risk in other patients, then the 20 is what's recommended. And now the 21 I've mentioned in terms of NACI, because this is a July, that was November, they've added the 21. So what's paid for, what's publicly funded is for children, a 15. That's changed from the 13. For over 65, the Prevnar 20. So that's where we have paid for in Ontario. For those of you outside of Ontario, I apologize. But again, our resources do include that. Well, here's what's sort of important. I'm not going to test you on all the different serotypes. That's not what's important here. But what I want to show you is that on the far left here, these ones in red, these are the 7 serotypes that were in PCV7, which you remember was the first pediatric vaccine. And then from there, they added a few for 15, a few more for 13, a few more for 15, and then a few more for the 20. What's happened with the 21 is went a little different here. They said they've taken out the ones that were in the 7, and they've added on a bunch of the serotypes that are causing adult illness and causing serotypes that are resistant to antibiotics. So therefore, the Prevnar 20 you can see is a very, very good vaccine, and it's hands down better than what we were using before in terms of 23. It's a fantastic vaccine, but there's still some potential holes in there in terms of coverage. And the question is how important it is. In addition, if someone has not had the previous vaccination with the 7 of some kind, then there's going to be a hole in their vaccine coverage for these serotypes. Okay, so it's 20 to 21, but it's not just adding one, it's taking away these and adding those 11 serotypes there. So how is this important? Well, if you look at invasive pneumococcal disease by serotype and how we're doing, and this is 2020, and it's a little bit different now. It's hard to get more accurate data from this, but it's not terribly different. What you can see here, V16 is that 21 or Capvaxive I mentioned to you. So 23 seems to beat 20, except it's not a very good vaccine, doesn't do a good job for memory and so on, but it does cover some serotypes. And that's why we added 23 to 13 and 15 to give it a little bit of a boost. It wasn't felt to be necessary with 20. You didn't have to give 23. But if you compare Capvaxive, the 21 to the 20, what you're seeing is that there's a significant number there, 26, 27%, that are actually not covered in the PCV 20. So we have some serotypes that are causing adult illness, causing invasive pneumococcal disease that are not covered with the 20. So 20 is great. The question is, for those patients who are high risk, is the 21 better? Okay, so what's important here is you look at serotype distribution of those that are resistant. So the ones that I've circled there are the ones that tend to have antibiotic-resistant organisms. These are those there. And the ones that are in red, so these are all the vaccine-resistant organisms. The ones in red are the ones that are in Capvaxive, the 21. So not all of them, but some of them are. And 19A is covered in 20 as well, so it's fantastic. That's one of the bigger ones for antimicrobial resistance, as you can see. But there's a few significant, if you add this up, it's a significant number. It's 27% or so of serotypes that are going to be resistant overall and not covered in the 20. So to me, that's an important thing. And the higher risk you are, the more I think you need to have a serotype that could cause antimicrobial resistance covered. Okay, so we did this survey overall to sort of talk about pneumococcal vaccine. So that's the science. So I've given you the science here behind what the different vaccines are and so on. Let's talk about pneumococcal vaccination overall and the barrier that the RESPIPLUS did with the partners I mentioned to you. So we looked at patients and healthcare professionals to look at awareness, to look at barriers, and to look at what people are actually doing or getting. We had about 380 respondents across Canada. Here's our partners of this: National Institute of Aging, Lung Saskatchewan, Family Physician Airways Group of Canada, which I'm the chair of, and the Lung Health Foundation, along with, of course, RESPIPLUS. So in terms of patients, we had almost 250. They were usually over 65 because they had both interest potentially in time, mostly Ontario and Quebec response. There was comorbidities here: asthma and 20%, COPD 85%, heart disease, and 20%. That's a pretty big number. Were immunocompromised. So these are the patients that answered. And if you look at healthcare professionals, we had nurses, family doctors that had many years of experience, 2/3 of them. Quebec more so than Ontario, and urban a little more than suburban. You can see the breakdown of the different. There were some specialist physicians as well. There were pharmacists here as well, and nurse practitioners as well. So what did they say? Well, in terms of patients and healthcare professionals, they were overall aware that pneumococcal illness was an important thing, that pneumonia was something that's important and it's something we can actually prevent. But there's big holes in how they did that, especially in the patient side of things. Uh, do they have conversations, the patients, with their healthcare providers? Yes, they've had the occasional discussion, um, but a third rarely or never discussed it. So that's a significant number. They've not talked about it at all. Right? In healthcare professionals, they were familiar with pneumococcal disease, but I can understand why there'd be some barriers. I mean, we have some vaccine fatigue, which I'll talk about. There's lots of vaccination people need. People don't, people, paying for it becomes a conversation. The pneumococcal vaccines keep changing to add on more serotype coverage, so it's a bit of a problem for them to keep up on that. Let's look at those barriers. So the big ones, overall, were cost, awareness, and vaccine fatigue. So patients were aware of the risk. We said 80% knew pneumococcal disease was important. And overall, were there barriers to actually getting the vaccine? Was it convenient to get the vaccine? That was actually found to be one of the bigger barriers. Cost was actually not such a big barrier for patients. I mean, 1 out of 4, it was a barrier, but we thought as healthcare professionals that was the big problem. In fact, that's not true. So a key caveat from here is that if you don't offer a vaccine, some patients will ask for it, but the majority will not. So the number one predictor of a patient getting a vaccine is their healthcare practitioners recommending it. So don't assume, what happens when you assume, right? You make an ass out of you and me. Don't assume that patients are not going to pay for it and then don't even recommend it. You recommend it, it's their decision whether they want it or not, and they're within their rights to say no, but most of them will say yes. Now, there's been a lot of vaccines. I say, what do you mean? Another vaccine? I've had 6 COVID. I've had my flu. I've had my shingles. I mean, all these shots, and you want to also give me a pneumonia one. Well, wait a minute. Doesn't RSV cause pneumonia? Like how many pneumonias? So that's tiring. There's been a lot of shots, and that takes up time and it takes up money and it takes up effort, but both clinician and the patient. We have to recommend it and the patient has to go for it and get it. Fortunately, we now have the great partnership of pharmacies here. Pharmacists are giving a lot of these vaccines. Thankfully, during COVID, they took over a lot of that responsibility. The Covaxon system made it very laborious to do this in offices. So thank you, our pharmacy colleagues. And many of those patients that got in pharmacies were not the ones that even got them in physician offices. So they used as an alternative healthcare practitioner for them. So again, you can't get all vaccines in all pharmacies, and some they have to pay for or not. But the bottom line here is we have opportunities here to get people vaccinated. All right. So patients are getting recommended for vaccinations at least once, and probably about 2/3. 10% at every visit. Well, I must admit, I don't recommend it at every visit, but hopefully I've already talked about it and they've been vaccinated. So personally, I'll say that I don't do it every visit, and that's going to be a little much because people come in for many reasons. But actually, healthcare practitioners said they recommend every visit, and just under half, but especially when they're co-administering other vaccines. So when you have a vaccine, it makes you think about other vaccines. So flu season, very important to talk about other vaccines and get them set up. And again, where do they get their vaccines? Depending on which ones, depending on which provinces. Sort of 2/3 in the pharmacy, 1/3 in the family docs. But again, it'll depend on which vaccines. But again, we have opportunities there. If you're from Alberta, as you know, many of the vaccines are given in public health. So it's taken away from the family doctor responsibility, other than new ones that are not paid for. So where do we agree and disagree in this survey? Where we're in talk about. So in terms of agreement, convenience was thought to be very important. And most patients felt that they actually could get a vaccine if they wanted one from their doctor or the pharmacy. And they felt that it was important to be reminded. So that every visit maybe isn't such a wrong statement overall, and they'd like to have a little bit of education about vaccination. Where was the survey different? Well, we actually, as healthcare practitioners, overestimated the concept of vaccine fatigue. So yes, we're tired of talking about vaccines because we get it. We have lots of other things to talk about it. We think the patients have said, "No, I don't want any more. I've had enough." But in fact, it's our job to recommend it. It's our job not to assume that cost is going to prevent them from getting a shot. But what they do prioritize is convenience and healthcare practitioner recommendations. So we need to make it convenient. We need to actually recommend it. During flu season, I would often have flu clinics. I'd open up on a Saturday and you can all come in and get your flu shots. We'll give hundreds of flu shots that day. This is not the day to ask me, tell me how depressed you are, because that's not the time for it. We'll make another time for that. This is the time to get shots in arms and make it done efficiently. So I really like the diagram that the RESPIPLUS team found on the right for this. How do we overall improve this? Well, we have to enhance patient awareness. We have to recognize that this is something that patients should be expecting. They should be wanting vaccines. They should be wanting to prevent illness, vaccine preventable diseases. And we have to recommend it. We have to make it easy to get. We have to figure out a way of tracking it. Big issue I'll come back to. Are there other ways of expanding this with community initiatives with public funding to do that? We had some tremendous approaches to vaccines through COVID. We had walk-in clinics setting up. We had drive-through clinics. I worked in one in Stouffville, were set up by one of the local doctors, and patients would literally drive through. They wouldn't even get out of the car. We'd reach over, give them a shot in the arm. We documented who they were, and it went through. And overall, what are we going to do to reduce disease burden by putting all this together? So, what do we focus on? Education. Well, thank you for coming today because this is part of it. Accessibility. Well, coverage for some of these things is now there through the government. Proactive engagement. We have to speak to our patients about this, about the need of vaccines. The higher the risk you are, the more the conversation should occur. Anyone over the age of 65, anyone over the age of 50, especially with comorbidities, immunocompromised, as you can think, is even thinking about this in pregnant people, not for pneumococcal disease, but pregnant women have a higher risk, as you know, of getting COVID and having bad outcomes, of having influenza and having bad outcomes. And as you know, our pregnant women will get a Tdap in pregnancy or pertussis shot in pregnancy. And now there's even an RSV shot in pregnancy to give the baby immunity on delivery. Accessibility. I talked about opening up on a Saturday for shots. Is there some kind of rural reach program? Is this going to happen in the pharmacy or community clinics? Where can we do this that we can actually get shots into arms and make it easy for patients to come? They don't want to take a half a day off work to come see you at 2 o'clock in the afternoon. How do we actually make this accessible? And that means a little bit of on our side as well. How do we actually keep track of the immunizations? And I'll come back to this. Can Immunize is an app, and I'll come back to that. And again, it's a constant conversation. Maybe not every single visit, but recurrently through the year. We did say you need shot A, B, C, and D. Which ones have you had? I gave you a prescription for it. You haven't had it. Would you like to have it today? We can get it from the pharmacy in the office or down the road if you'd like. So overall, how do patients like to get information? To get it online, which is interesting because our population was over 65 and still 2/3 of them said they want it online. They want to get it from the doctor, 4.7 out of 5. Okay. Clinicians want to get information from webinars. So you came today, so thank you. And public campaigns and CME linked training overall is going to help bridge those education gaps. So we need to get this both to the public as well as to the clinicians. So how do we track this? So many of you are familiar with those yellow cards that if you have children, you know that you got your vaccines, you brought in the yellow cards, the doctor wrote down, checked off which shots they were, and that was your lifeline to vaccines. Now that we have electronic medical records, electronic health records in offices, it's a little bit easier to keep track and so on. But of course, you have to enter it. You have to do it properly. But what is the patient going to do if you have it in your office? Sometimes I'll print out the page and give that to patients, but the Can Immunize app is an opportunity to do this. Now, it's far from perfect. It has some things that it's really hard to enter. It does give you reminders, but it's kind of hard if you can't enter it. But it certainly can give patients an opportunity to sort of list their vaccines. So this is something I've been recommending to do, and for the patient to keep track. They need to be the keeper of their own medical record. All of you have had patients that have come in and said, "What medicines did you take?" I don't know. Did you bring them with you? I don't know. So it's really hard. What vaccines have you had? I don't know. The doc knows, right? So so I do consults as well. So when someone comes with my doc knows, look, so that's not going to help me because I don't know what you had. So let's think about this. Vaccine reminders as a routine. Perhaps that gets sent out from the offices. A lot of offices are using electronic outreaches to do that, and we can do that. And Quebec already has electronic vaccination records in place, so patients will have access to their own records. Well, this is wonderful. Why is this not everywhere across the country? That's a very good question. So again, we've talked about better accessibility. Will there be public funding to reduce costs and get these shots into arms? I doubt it. I doubt we're going to get more money. So we're going to have to figure out how to do this with our healthcare system that we have. But let's certainly simplify the vaccine schedule and make the communication important. So overall, if we can get some education, logistics, and public funding, get reminders that occur a number of times, because pneumococcal is not a seasonal vaccine. Influenza is a seasonal vaccine. COVID is a multi-seasonal vaccine, but it's a seasonal vaccine. Shingles is not a seasonal vaccine. So we can give this any time of the year, not just during flu season. How do we track it? How do we target the campaign for those high-risk patients? How do we make sure they get their shots? So the conclusions of the survey were uptake isn't what it overall about pneumococcal disease is the vaccine uptake is not what it should be. Okay, only about a half of people over 65 and a quarter under 65 are at high risk. The target was 80%. We have lots of opportunities. Our patients come to see us in the office. They come to the pharmacy. They come to see us as the primary care doc and the specialist. We all need to be consistent in our recommendations. Okay, not just flu shots, but all the other shots as well. That if we can get people's shots into arms, then we also have to think about getting the right shots into their arms, getting into them the serotypes that are actually causing illness. And this is changing. We've gone from 7 to 13 to 15 to 20 to 21, as I've described to you. And this is going to continue to change because Mother Nature, when one serotype, is protected and covered, it's not the active one anymore. So new ones become the active one. So Mother Nature doesn't do that. It's not the variants like COVID where it's changing. These are serotypes that exist. So we know that they're out there. They just haven't caused enough illness yet to provoke making a vaccine against them. This is going to change as Mother Nature change. And hopefully we can deal with these awareness barriers by things like this webinar, but also conversations with each other. So here's some examples of overall recommendations to groups. So this is goal 2025, and they've been consistent over the last few years where they have a slide talking about vaccination. In the GINA guidelines, which I'm involved with as well, we also have vaccination where we talk about some of these vaccines for asthmatics as well. So yearly influenza vaccine, COVID vaccination, either a 20 or a 21 pneumococcal vaccine, RSV over the age of 65, and or with chronic heart and lung disease, because there's now good evidence for both RSV vaccines for over the age of 50 with disease. I've talked about pertussis and tetanus with pertussis, and zoster over the age of 50, but even over the age of 18 with significant comorbidities. So it's all there. We know that asthmatics, young asthmatics, especially if they're on significant dose of inhaled steroids, will have a higher risk of pneumococcal illness. So you're thinking about all these patients who are at risk in your practice. Your diabetics, your congestive heart failure, your cardiovascular diseases, your renal disease, the list goes on and on. These are people we have to be targeting. But there are some very real barriers. I get those barriers. People don't want vaccines. They feel they don't need it. They feel that others are getting the vaccine, so they don't have to. We know the vaccines don't cause autism, a whole other conversation. So I think that if we do get a vaccine against becoming a zombie, if you're into zombie movies, then you'll like this one. How do we communicate? So this is some interesting stuff that I saw. This is adapted from BC Centre Disease Control. How do you discuss it? So one is participatory, where have you thought about getting your shot this year? Okay, versus presumptive. Flu season's coming up. I can give you your flu shot today before you leave. Okay, why don't you roll up your sleeve and let's get it into you? So one is, planting the idea, which maybe is a good thing for off season. The other is saying, hey, you need it. I'm worried about it. Let's give it to you today. One is communication, motivation interviewing. It's dismissive. You don't need to worry about it. Someone says, I heard that vaccine can cause side effects. You say, no, don't worry about it. Whereas when you talk about it from the patient point of view, you say, Well, I hear your concerns. So let me understand your point of view. Let me understand what your concerns are, because maybe they're not exactly what the data shows. And you've heard many people with lots of concerns that are not true. If you talk about COVID now, the risk of myocarditis from the new COVID vaccines is virtually zero. It's not a problem anymore. Okay. Do you personalize it about the person or just say, well, NACI or Canadian Immunization Guide recommends that vaccine, so everyone should have it because that's what's important? Or do you say, you know what? I'm worried about you. I think you need it for your reasons. And furthermore, I got kids. I made sure my kids all got vaccinated. I'm getting up in age. Okay. I've had all my vaccines, all the ones I'm recommending to you, I've already had. That's a personal thing. And you're saying, hey, I'm in this together with you, both personally and professionally. Let's do this. So, with all that, think about this. How can you change your practice tomorrow based on this? And I hope I've given you some ideas of things you can do to talk about it, to recognize that if you have an EMR, to look at the section and make sure you're up to date, to try to plant the seed, to put up posters in your office, to ask about it when people come in. Here's some of the resources. These links are not active right now, but they will be active when Maria and team sends out the next stage of things. And I think you'll find very nicely in the report there, all the report we talked about, as well as the rules in the different provinces for coverage. And I talked a little bit about not asking why. How do you approach vaccine persuasion? I've given you a little touch on that already right now. So that's will be a link to that as well. So here's my email, 44kids@gmail.com. Yes, those are 4 children I have, and they've all had their vaccines, as I talk about. Here's the RESPIPLUS website that you can get a lot of the information and have a lot of other tremendous programs that are hosted on the RESPIPLUS site, and you can ask some questions, info@resplus.com. So I'll leave that up, Maria, and open it up to you to bring up some questions. Let's have a conversation. You're muted, Maria. Sorry.
Sorry. So I was just saying, thank you, Alan, and I really love the presentation because we could see the results of the survey. I think just to um, compensate with what the science and the new guidelines like NACI are recommending and where we are today in terms of vaccination. So the floor is open for questions. Since there's none right now, I'll ask them. And Alan, can you just comment more about the length of immunity provided by these vaccines?
So conjugate vaccines last for many, many years. Where we talk about length of immunity was with the Pneumovax 23, the polysaccharide vaccine. Its immunity was shown to wear off quite significantly starting about 5 years. And certainly by 10 years, there was nothing left because, as I said, all it did was create antibodies. There's no memory. So the 23, the polysaccharide, ran out. Conjugate vaccines have memory. They cause T cells and cause memory. The Capita trial, which is a huge trial done for Prevnar 13, showed 5 years of data, and the lines continue to diverge between those that were treated and not. So there's memory there, and it's probably lifelong immunity for conjugate vaccines. But we're changing vaccines. We're moving it up. It's not because we're boosting. We're not boosting. What we're doing is we're adding serotype coverage to those serotypes that have been causing illness, causing IPD, causing acquired pneumonia, causing hospitalization, and most importantly, causing serotypes that have antimicrobial resistance. So it is good for life, but we're adding things because the serotypes that are causing illness are changing.
Perfect. That's much more clear. So, um, the next question is about the cost, and it was a surprise after the survey, and to see whether it was a preoccupation by the healthcare professional, and yet it was not the same from the patient's side. Can you talk about the situation in Ontario, specifically how much it costs, what is covered? How do you have this conversation with patients?
Yeah, so the cost is around $120, $140 depending on the pharmacy. I know this because I just purchased the Cap vaccine for myself, even though I've just hit 65 and the 20 would be covered for me. For whatever reasons, I thought that it's important that I have the additional coverage. So I do practice what I preach. And furthermore, we also got a shot for my wife, so she's going to get it as well. So I think that additional coverage is important. I want to prevent everything I can prevent. Okay. But I'm also one of those people that is close to 100% adherent with the medications he takes. So that's an overall consideration. Who is in front of you in terms of the patient? What do they want? I've got a good friend of mine who's a lawyer, and he says, I don't care what anything costs. You just make sure I stay well. Right? So that's an attitude. Now, some people don't have that attitude, as you well know. Okay. Leave me alone. I don't want to take any medicine. I don't want any vaccines. I certainly don't want to spend any money. Fine. Right? You have the conversation, you make the recommendation. Now, and then people say, well, why does the government pay for some and pay not for others? Well, because it takes them a little while to catch up. We know that influenza is being paid for by our governments, not because our government really cares about you. And sorry, this is probably being taped and it'll be repeated, but they're paying for it because it saves money. For everyone who gets an influenza shot, it actually decreases healthcare costs across the province and the country because it prevents illness. Now, you'd think that these other shots should also be covered because they also prevent, and yes, in many provinces now, Prevnar 20 is covered because it prevents illness. It's worthwhile. Not every province. As I said, BC, it's not covered, and a few others as well. And again, in the resources Maria will send you, you can look up your individual province or look it up online because they're all a little bit different. But coverage. So Canadians, people think everything should be free because they're used to being free. But again, my conversation in a motivational interview approach is what's important to you? Well, it's important for you to stay out of the hospital. It's important for you not to die. Okay, that's not. Is it important for you to be independent? Well, wait a minute. What does that mean? Well, we know that a certain percentage of people, after they end up in the hospital with any of these respiratory illnesses, never get back to baseline. Okay. A third of them for sure are not getting back to baseline by 6 months, and probably 10% plus may require assisted living of some kind, either going to a new location with a nursing home or something like that, or have to be a burden on their family. That gets people's attention. That's a pretty big deal. Wait a minute, I don't want to be dependent. Well, then keep yourself from being ill as best you can. Certain things you can't prevent, but you can prevent some. So it's a discussion you have with these people, and it's about what the patient really wants. So the job here is to introduce the topic of vaccination. Okay. Well, I don't really think I want one. Well, okay, why not? But let's talk perhaps about what you think about vaccinating. What's it going to do for you? Okay, what'll stop me from getting pneumonia? Well, what will pneumonia do to you? Well, I'll get sick. I'll need antibiotics. Well, you're 65 years old. You know that a significant percentage of people 65 that get pneumonia end up in the hospital. Okay, well, I'll go in the hospital. A week later, I'll come out. Yeah, but how will you be a week later? And that you build that story. And what's important to you at the end of the day? Where would you like to see yourself, 5 years from now? Right? As we get older, you start thinking about the future, right? So what do I want to happen in 5 years? Do I still want to be in my own house? Do I want to be somewhere else? Do I want to be independent or not? Will I be able to be? These are all things you start to consider as you age. And for those of you who are younger, trust me, it's going to happen to you too. That's what happens. So I think, Maria, it's that entire conversation about what's important to them. The cost, in fact, I've shown you from the survey, and we know this from other data, that most people, only 20 to 25% cost is a very real barrier. Everyone else, if you sort of say why it's important to them, they'll pay for it. How much is $140 in terms of Starbucks coffees? It's about 15, it's about 15 coffees, right? I mean, it's not an important thing. I mean, look at the big picture. People are mostly willing to pay for it, even those who are financially less advantaged. So I think it's important for us to offer, even though that cost is there. Make sure you don't make the assumption that they don't want it because they won't pay for it. Lastly, one other thing about making the recommendation, please. I hope there's no lawyers on the line. Maria, we do screen and make sure there's no lawyers allowed on our phone call, right? So it hasn't happened yet. But here's a scenario. Just imagine. It'll work better as a shingles example. So someone is 60 years old and they should have had offered a shingle shot. We know that the risk goes up at 50, even more so at 60. They haven't even been recommended. You didn't even recommend a shingle shot. Didn't talk about it. Too much trouble. I don't want to get into it. Enough to talk about it. And then they get shingles. And they come back to you and say, well, I understand that I should have had a shingle shot. It would have prevented this chronic pain I now have that I'm now on all these drugs for. My life is miserable. And you didn't recommend it. Why didn't you recommend it? Well, wait a minute. Isn't it recommended? Shouldn't you have done that? Maybe I should be speaking to a lawyer here because you didn't do your job. And because you didn't do your job, I'm now living in chronic pain. This has not happened yet. There's not been a legal precedent. But I think it's only a matter of time. So I want us to prevent illness, protect our patients, but clinicians, you also have to protect yourselves.
Yeah. I totally agree with what you said, Alan. I think that's a good way to engage the conversation with the patient, and it's a broader answer than just the cost. There's a couple of questions from the audience. So it says, so do you recommend Prevnar 20 and 21?
Yeah, really good question. Right now, NACI's recommendation is to give 20 and 21 only to people with hematopoietic stem cell transplants because they're the highest risk, as I mentioned. However, if we think that a good 20 to 25% of of the serotypes that are not covered in 20 are serotypes that are have antimicrobial resistance, right? Which means if you get that serotype, antibiotics aren't going to work. Hmm. So if you're higher risk, should you have it? So I've had 20 and I'm going to get 21 as well. Okay. Because I think that risk is significant enough for me. I think you have to look at overall the risk. If someone's very low risk of getting very ill, then probably it's not worth the trouble. If someone's very high risk of getting ill, then you have that conversation with them. They've had the 20. Do you want to have a 21 now? If they've had a 20, how long do you wait for the 21? That's a good question. NACI has not answered that at all yet, but I can tell you that from the 13 to the 20, they recommended waiting a year. So my recommendation would wait a year from the 20 to give the 21 if you're going to give it. So this is outside NACI recommendations. It's outside the CDC's recommendations for now. For me, it's an individual conversation I have with the patients. So my person who is in their 60s with severe COPD and FEV1 of 20% that have had 20, they get bacterial pneumococcal pneumonia, they're going to be in very large trouble. I'm going to recommend that to them. And most people have decided, okay, I'm going to have that because I'm trying to reduce the risk for them. And I explain why. Do they have to have it? No. Um, is it even recommended by NACI right now? No, it's not recommended against. It's just not recommended for. Right now, it's 20 or 21. The only proviso about 21 I'll say is if they're going to have only one adult vaccine, the 21 is probably the right answer as long as they've had something previous. So those previous 7 serotypes are also covered. Otherwise, give them the 20 to start with, it's covered, and then you can think about the 21 next if they've not had anything prior to the 20.
And just a little follow-up to that, Alan, is a similar time interval. Would you do the same, like waiting 1 year with high-risk patients? And again, this is
Yeah, we
recommendation.
don't.
This is
Yeah,
not
yeah,
written in the
yeah,
NACI or anything.
yeah.
Yeah.
We don't know the answer of that, Maria. And my answer right now is going to be a year. I think the we don't there is something about giving vaccines too soon. We learned that from COVID, that if you give a COVID vaccine too soon after the last one, you don't get the benefit of it as well. Now, it's a different disease entirely, so I don't know. But right now, in the absence of having any data or any real evidence, I'm going to say a year between conjugate vaccines. Now, if you had a 23, and if you had a 23 as well, let's say a 23 and a 15 or 13, then you got to wait a little longer because the 23 causes the fatigue that you're familiar with. So we're still probably talking about at least a year. So for sure a year if they've had a 23, which hopefully people aren't going to get anymore. By the way, if you have 13 and 23 in Ontario in your fridges, give them back to public health and order 20s. You don't need to give 13. You don't need to give 23. You're giving 15 to children and give 20s to your people at risk. So that's there. So right now, Maria, my answer is going to be a year, and
Yeah.
it's a bit unclear, unfortunately.
And I
And as
think that
far
closed the other question, which is what is your recommendation for PPV 23 and the
okay,
conjugated vaccines, right?
okay, Pooja, you're welcome. And the 23 is an archaic, inefficient, almost useless vaccine. And it was useful a little bit as an add-on to invasive pneumococcal disease. It's never really had good data for pneumonia. And I should mention that Merck is the sponsor of this, and Merck is the one who makes the 23, so I'm dissing my own sponsor. However, that being said, it was not a very good vaccine, but that's what we had. Conjugate vaccines mostly replaced it, although the government decided they'd still pay for the 23. Made no sense to me. Finally, the governments in Ontario have caught up and they cover the 20. That's great. 20 is made by Pfizer, by the way, again, different company. So I'm putting all this together to say, hey, what's the best vaccine for your patient? 23 is pointless. The only thing about 23 is you do have to wait a year before you give anything else after that. Okay. So in the old days for conjugate vaccine, you could wait 8 weeks, and now we're talking about a year. So um, 23 is something that is now a thing of the past, Maria, thankfully. If anyone's been given one recently, then if you want to give something else, you have to wait a year before you give something else in terms of a conjugate.
Alan, I just have one last question, which is how do you see the role of the family physician? And also many people here in this webinar today are other kind of educators, nurses, RTs. How do
Hmm.
we see them working in their own responsibility and as a team?
Well, I think that the best healthcare patients get is when the team's involved. And especially if everybody is speaking from the same playbook, so to speak. I'll use a sports analogy. If we're all saying the same message, then the patients are hearing it from a number of different places, and they're more comfortable with hearing about it rather than thinking someone's trying to push their own personal agenda. So no matter what you do as you interact with patients, we all want the same thing. We want them to not smoke. We want them to eat healthy and keep their weight optimized. We want them to live healthy. We want them to protect themselves. We want them to take their medications. Okay. We want them to do cancer screening. We want them to immunize. All those things are things that are actually going to keep them well. No matter where you're coming from in the healthcare journey of the patient, we can actually make a difference by telling them the same message and encouraging them. And if they have questions, helping to answer them. And I hope I've given you a lot of the ability to answer those questions with the webinar today. It doesn't mean you're going to be personally vaccinating or you'll be personally writing the vaccination prescription or whatever, but that doesn't mean that you can't say, hey, have you thought about getting your pneumococcal vaccine? Have you thought about getting your RSV vaccine? You should write this down and go talk to your doctor about this when you see them next. And that may push the doctor to do something maybe they wouldn't have remembered. So there's so many different ways we can work together to optimize the health of the patient. Maria, thanks. That's the way we work together to help our patients in front of us.
I agree. I totally agree. And there's no more questions. So thank you again, Dr. Kaplan, and thank you everyone for joining us today. We also thanks our sponsor, Merck Canada, for supporting these and many other learning opportunities. Um, you will be receiving in a couple of days an email with the link to watch the webinar, the replay, but also with this report that we've been talking about. And thank you again for coming at your lunchtime. For many of you, have a good rest of the day.
Okay. Thanks everyone for coming. Maria, thanks for all the arrangements. And everyone, take care of yourselves. All right.
Bye. Bye.
Bye bye.
Thank you.